Hello, everyone. Welcome to another round of Doc Talks. Today, we have Dr. Scott Kopetz with us. He's a professor at the Department of GI Medical Oncology, Division of Cancer Medicine at MD Anderson. He's also the NCI Colon Cancer Task Force Chair. And I don't think that Dr. Kopetz needs much of an introduction to the people in Colon Town. So thank you again for your time and welcome.
Oh, thank you so much. These are always so much fun, and delighted to be able to share some thoughts and hopefully have some great discussions here as well, acknowledging what we know and also what we don't know about this field, which is rapidly evolving. So wanted to go through some background and kind of fundamentals here, and then try to talk about some of the some of the areas, and I have a number of frequently asked questions at the end that we can use for discussion, and then go from there. So, okay, so what are we talking about when we're talking about circulating tumor DNA? And I see my idea here really is thinking about how do we focus on minimal residual disease in colorectal cancer. So I think acknowledging that this is all enabled by just a tremendous technical advances in sequencing that really allow us to find the proverbial needle in the haystack, that we're looking for a DNA fragment in circulation among just a tremendous amount of normal DNA that's shed on a daily basis into the blood. And that we can then see these very rare DNA fragments that, because of our understanding of colorectal cancer, we know is coming from a cancer cell. Now, this is enabled because we can sequence incredibly deeply, but also that we've gotten as a field very good at not having errors in the sequencing, right? There's been methodologies to improve it, so we're not dealing with as many sequencing errors as we did before. So, the key point that I wanted to make is that there are a lot of liquid biopsy tests out there. This is not circulating tumor cells, so CTCs. So circulating tumor cells are ones that that are not as sensitive in colorectal cancer, where you're actually seeing intact cells from the cancer. We're looking at fragments of DNA. The other key point is that what we'll be talking about really is different from a molecular profiling circulating tumor DNA test. Ones that it's really about what are the mutations that are present in the tumor and how are they changing over time. We recognize now that there's really two different flavors of these tests, really MRD, circulating tumor DNA tests, versus the molecular profiling, right? So you'll see things like, Foundation 1, Guardant 360, things like that are really designed to be more molecular profiling, but are not the ones that we'll be talking about today that are more designed for minimal residual disease. Now, why am I excited by this? What we see is that these assays are really a next leap in sensitivity. And I kind of put this in perspective. It's all about how many cancer cells are in the body before we can detect it, right? And in best case scenario, a chest X-ray may be able to detect 1 billion cancer cells, right? And we were excited as a field with the leap into CT technology, right? That allowed us to, have a 2-log improvement at least in the sensitivity of what we can detect. And now we are recognizing this is another several log improvement in sensitivity, meaning 100-fold or better sensitivity for these, and that we can detect a much smaller amount of cancer cells. Now, these numbers are gross estimates, and there's a lot of variability and other things that impact this. So we use this term minimal residual disease just to mean that the presence of cancer cells or cancer in the body below the limits of detection. So if we kind of use those numbers from the prior slide and put them here on the y-axis, you can kind of see, you know, around 10 to the 7th, we can start to detect things by CT scans, and that there's a proportion down below that are not detectable by imaging. And then at some point, there's zero tumor burden. So there's a little hash marks there where, you know, it's zero cells in the body, and that of course defines cure. And so we think about this concept of, you know, well, there's this space below where there's cancer cells in the body below what we can detect, and we call that, you know, minimal residual disease terminology. And that's kind of key. No radiographic evidence of disease. Now, I've now built, as you can see, that there are, we're talking about a proportion of minimal residual disease that we can actually detect by ctDNA. This is a great improvement, but it's not that we can detect down to 1 or 2 cells in the body, right? So there's still a proportion of patients that may have 1,000 cancer cells in the body, or a lower amount of disease that we still can't detect by either imaging or ctDNA. So this is a great advance, but it's not perfect, and we'll talk about this a little later. What does it mean when we do this? Okay, so let's talk about how these perform, right? And what do these mean? These curves, I know that very common, and we'll come back and reiterate in a little more detail a little later, kind of a refresher on these, what we call Kaplan-Meier or survival curves. But what this tells us is the amount of patients that have survived without any evidence of disease over time, depending on what category they were in the post-op setting. So in patients that had stage 3 colorectal cancer, where there was an immediate post-op test that was done, we can see, and these are some early data here, we can see in those patients that had detectable ctDNA, but nothing on scans, what we see in the orange line is just as time elapses, a number of these patients then had disease appearing on the scan. And this is actually percent survival without recurrence. So this is, if patients recur, you can see each of these little drop downs is a patient that is having a recurrence. And you can see that a key feature of this is that that there's a near 100% positive predictive value. What does that mean? It means if there's positive test that was seen post-operatively, it may take 2 years for things to appear, or in this last patient, even 3 years. But these are patients that at some point radiographically recurred. We didn't have any patients in many of these series that did not with sufficient follow-up. So we talk about these curves going all the way down to the bottom. But we also recognize that the sensitivity for a single test is not, is not perfect, as we mentioned on that last slide, that there's some that we can detect, but some that we can't, because it may still be too low from our level of detection. And for a single test, we talk about maybe about a 50%, some series as high as 70%, but I think 50 is kind of a good number to think about sensitivity here, which means that there are still patients that with a single test, you may miss, right? That they were perhaps lower levels of disease, but then the disease kind of grew over time, and maybe several years later, the disease recurred. So that's why we'll kind of think a little bit about the idea of serial testing in a little bit there as well. And then we'll talk more about this idea of, well, how long does it take between the time you have a positive test and things appearing radiographically? And this varies widely by series, but just another concept that we'll talk about. So the idea, now back to our graph here, is that can you take a patient, that had disease that was visible, resected, and maybe resection and adjuvant, but we'll just talk about some definitive treatments here. And there's 2 scenarios that you can see, right? There is the patient who had all the tumor removed and it was, patient was cured, or patients that had a disease that was removed and that nothing seen on scan, say they were, in remission, NED, no evidence of disease, but detectable by ctDNA, and it's a matter of time until it appears by imaging. And that's kind of the concept that we're getting at. So there are some commercially available assays. There's kind of two major ones that are being utilized now. We won't really get into a lot of the details of the differences between the assays, although happy to discuss that if of interest. There's the Guardant Health Reveal assay and the Signatera from the Terra assay, and there's undoubtedly be more coming in the next year. These are currently covered by Medicare and most insurance companies for colorectal cancer, not necessarily for other GI cancers. So what we'll be talking about today is really kind of colorectal cancer specific. Now we had some updated data, some Japanese cohorts. Dr. Kotaka presented the CIRCULATE-Japan investigators. Have a very large prospective cohort that they've been accumulating. I won't go through all the details, but what we'll be presenting is this kind of observational cohort where they hope to accrue over 5,000 patients to really understand the natural history of this. And this was an early update of 1,000 patients in this analysis here. They were looking at a number of different factors, and I'm just going to highlight a few things that I think are relevant. So don't get overwhelmed by all the arrows and the numbers here. But a very large patient population. So this is about 10 times larger than a lot of the other series that we've seen to date. Now, the outcome, the data updates, we don't have a lot of mature data. So this is only about 18 months of follow-up here. But what you can see is when you look at that immediate post-op ctDNA, so this is regardless, this one would, whether or not they got adjuvant therapy, we're just looking post-op for every, all stages, 1 through 4. Here you can see a separation of the curve. As we showed before, the patients that are ctDNA positive, you can see here, we would expect over time, given more follow-up, that would continue down based on our the data I showed you previously, and the absence of any adjuvant therapy. And then you can see the patients that did really well when they were negative, but still some patients that were having some recurrence. Now, if we focus just on stage 2, 3, you notice it's really not a whole lot different, right? So, going back and forth between the two. And I think this is the key point, is that we talk about how important stage is, but ctDNA looks like a really strong prognostic marker, right? I would say I would much rather have a stage 4 cancer that is, been resected and I'm ctDNA negative, than have a stage 2 cancer that's been resected and I'm ctDNA positive, right? So this idea of stages, it's something we're really starting to think about, like, is ctDNA even a stronger predictor than stage of disease? Now, the other data that we can talk about here, and again, I don't want to dive too much into the weeds, but really kind of thinking about, well, what about patients who then went on to get some adjuvant therapy and had changes in dynamics. So what you can see is that if you were able to get to negative with some adjuvant chemotherapy, for example, here in the green line, even if you're positive before, things look really good, right? You're almost on top of the line of patients that were immediately negative. Now we'll need more follow-up there. But if you were either positive and remained positive in blue, or were negative but then developed positive, you can see the recurrence rates are higher, meaning the lower curves. All right, final curve, and then we'll kind of we'll kind of zoom back up to the higher level discussions. But the final one is this idea of kind of clearance rate with the chemotherapy. And so these are observational cohorts, meaning This weren't randomized studies, which would be the highest quality, but what you can see is that with adjuvant chemotherapy, about 70% of patients at the end of 6 months were able to have clearance of their ctDNA, right? It was pushed it below the level of detection. Now, but there's also a small proportion of patients. There's like 4 or 5 different cohorts here. I think it's actually a smaller number, like maybe about 10 patients or so that were positive at some point early on, did not get any adjuvant therapy, but then actually had cleared spontaneously by about 6 months. So just acknowledging that there is a proportion here that we still need to better understand. There are a few percent that I think can happen. So how do we use this test? So if we go back to this this curve that we had before and think about patients that have detectable by ctDNA setting here. One question is, is adjuvant therapy needed, right? And traditionally, we've given adjuvant on the basis of stage of disease, right? But if I convinced you by what I showed you before, it's really not so much about stage of disease. It's really that ctDNA is such a strong prognostic factor that maybe that's enough to really guide who should get adjuvant therapy or not. And so if somebody is ctDNA negative versus positive, that could be a very different scenario. So there's a number of studies ongoing. There's a COBRA study that's been ongoing for a little while, led by NRG, that's taking patients in stage 2, where the decision was for no adjuvant chemotherapy, and then trying to understand the utility, randomizing to use the assay or not. So this is really high level 1 data to see if we can improve outcomes. And then there's just now launching is what the CIRCULATE US, which is a companion, or we're collaborating with CIRCULATE-Japan, T1 to 3 N1 stage 3. So what we consider a lower risk stage 3 colon cancer. We're looking at the ctDNA and actually saying if there's no ctDNA detected, we're randomized to either doing the adjuvant like we would normally, or as we showed before, these are patients that do really well. So maybe what we need is just serial ctDNA, right? As long as you remain ctDNA negative, there's no need for adjuvant therapy. In that setting, we are probably over treating majority of those patients. But if at any point during that ctDNA is detected, either initially or during surveillance, then those patients would go on to get treated. Now, there's a second question about, could we escalate? Can we do something a little more intense on to improve outcomes in those patients? So as I mentioned, this is kind of a jointly analyzed with the prospective Vega study that's being done with CIRCULATE-Japan. So this is obviously very different because we've always been taught as medical oncologists, if you have stage 3 colon cancer, you need adjuvant therapy. So here's actually the data, the non-randomized data coming out of Japan. These are all patients that were ctDNA negative after surgery, and this is stage 2 and 3, so high risk 2 and 3. And then asking the question, is there any evidence of better outcome in those patients who were treated with chemotherapy versus those that didn't with adjuvant with a negative ctDNA? And I think what you can see is that patients do very well. There are a few that still relapse, but there's really no difference that we can discern yet with the role of adjuvant therapy. So, so that's that's what we'll be looking at here. And again, not randomized, so we need these studies to understand. There are other studies, this is the Dynamic 3 being done in Australia and in Canada, just to be aware of, very similar, randomizing to either doing what you do normally or to be ctDNA informed. And the clinician would say, I'm picking what we're going to do, in discussion with the patient, no therapy, 5-FU, single agent or combination. And then the informed one, the physician would still make the same call. And based on the pre-planned, they would kind of de-escalate one level. So if if the oncologist and patient said, well, we'd probably do 6 months of 5-FU, and the ctDNA test came back negative, then it would be, we're going to do less 5-FU or just no chemo at all. And then conversely, if they said we're not going to do anything and it was positive, then they would escalate up in their treatment intensity. So that's the Dynamic 3 study. Now, there is this additional question of, well, can we do better than adjuvant than FOLFOX? Like, what can we do that could improve outcomes? And certainly, being better at treating the right patients is important, but we also want to make sure that we're improving outcomes for everybody, and that's where a lot of our excitement and I think the innovation is coming. So there's this phenomenon that we say, okay, if you have less than 10 to the 7th tumor cells in your body, we can give adjuvant chemotherapy and we can cure patients in that setting, right? We can take some degree of tumor burden and we can take it down and eradicate all the disease, right? But we also acknowledge that when a patient has metastatic disease that's visible on a scan, they've passed some sort of threshold of and past our ability to actually cure the patients, right? Aside from very rare subsets and MSI and immunotherapy, for example. But most settings, FOLFOX is not going to cure patients with metastatic disease that's visible on the scan. So we know that there's a difference between treating patients here and treating patients here in terms of our ability to eradicate the disease. So there's a lot of effort about novel therapeutics here that may extend life in this incurable state, but there's a lot of real enthusiasm and I hope momentum building around, well, if we can capture it down here, maybe we can actually cure patients. We can drive them down with novel therapeutics to be cured instead of extending life, but not curing patients there. So, so this is, I think, a really important point to understand about why early detection here may enable more novel therapies that may cure more patients, which is really what we want to do. So just share some of the things, some of the approaches. So this is an example of a study that I'm privileged to be able to coordinate. International study looking at these high, stage 2 or 3 that patients who've had surgery that are ctDNA positive using their kind of a proprietary assay that's that the BioNTech team is utilizing. Patients go on to receive FOLFOX and then get randomized to either get the vaccine or not, in addition to the best available FOLFOX here as well. So looking then at the impact. This is actually the same vaccine technology that's being used that BioNTech and Pfizer use for COVID, but it's really being personalized to an individual patient's tumors. These are ones that really have to have surgery in the center, or get to a center really quickly after surgery where the studies are being done, because it's not a whole lot of time in between the surgery and needing to get onto the study. But I think just an example here of novel therapies in that space. So the other kind of question and opportunity here is, even after adjuvant therapy, if we drive it down but don't eradicate it, and we keep watching patients with serial testing, we may be able to catch them, catch the disease, the MRD, before it gets to the incurable detected by imaging, right? And so the idea, can novel therapies cure patients in this setting? And I won't go through the details here, but this is a really efficient way to study minimal residual disease with this. And so the details here are not critical, but just to say, it used to take us 1,000 patients to do a study to ask whether or not a novel therapy in this setting works, right? When we were just having to treat a lot of patients to understand. And you just didn't see many novel therapies, right? The only studies we would test, the only therapies we would test in adjuvant setting, quote unquote, was things that worked in metastatic, right? So it was like, well, let's test Avastin, let's test cetuximab, irinotecan, regorafenib, and none of those really worked, right? But there wasn't any interest because it was deemed too high risk to put something completely novel like a vaccine or cellular therapy or immunotherapy in that setting, because they hadn't, you know, that 1,000 patients is a really expensive study. It was deemed high risk. But the setting now allows us to do small interventions, right? Let's try in 30 patients that have ctDNA positive, nothing evident on the scans, you know, but let's try a novel therapy that looks really promising and generate momentum and see if we can actually cure some of these patients. And from a drug development perspective, this is good because we need partners, pharmaceutical and industry and the NCI, to bring, you know, novel interventions together. So I think that's exactly it. This is a study that we did at MD Anderson. I think was, to my knowledge, at least the first to do this in colorectal cancer, looking at a immunotherapy in this setting. Again, 15 patients to get an answer. But there are a number of these going on. There's a RAS mutated patients, or patients that have a RAS mutation in their tumor. They're eligible for a vaccine study here in colorectal, and there's actually an effort ongoing in pancreatic cancer. But a number of these ongoing. So we have an NK cell and cetuximab that's just getting ready to open. If patients have an MSI high tumor, studies looking at doing immunotherapy early. TAS-102 is an agent that has a lot in common with 5-FU, and so there is some hope that that because 5-FU works so well for curing patients, that perhaps TAS-102 may also. So I think, you know, a lot of interest in that area. We know that certain things are associated with better outcomes, meaning that lifestyle may indeed cause some mild ctDNA positivity or be eradicated, right? So if we're saying, oh yes, vitamin D, aspirin, diet, and exercise is important in reducing a risk of recurrence, but what we're meaning is that there are some patients that have some residual cancer cells in their body, the MRD, but by these lifestyle, we can get the body to clear those on their own. So there's a really intensive, and this is good remote option for patients to really say, well, let's just throw everything we know from epidemiology data, really motivate, get dietitian, nutritionist, exercise engaged, and to kind of help walk patients through a really intensive program for a few months. Personalized peptide vaccines are ongoing, and this is another one with immunotherapy, targeting BRAF mutated patients, and I think a number of other ones in development. Then I will say there's this is a kind of a plug for some resources that some colleagues and I've helped develop, because this is a really rapidly moving field, and so certainly the Paltown is a great resource for you know, hearing about what studies are coming up in this setting. Well, there's also a CRC MRD website here that has, we're trying to keep up to date with the number of trials that are ongoing in this, and we'll have some additional resources that you can look at. And I'm so appreciative to a number of great colleagues in this space. I think we have more contributors coming on, but certainly Dr. George and Annie as well for their input. This is a priority for us at MD Anderson, just to acknowledge this is something that we've really been helping to push, and we've now have said this is going to be our standard for any patient undergoing resection at MD Anderson, that this is systematically going to be checked regardless of stage, and then with the idea that there are things that we can do. So, you know, we'll certainly, if there are patients that are undergoing surveillance and have a positive test, but nothing seen on the scan, there are a number of trials that are coming that could be considered. So, wanted in the last few minutes before questions, go through some of the frequently asked questions here and kind of highlight some of these. So first is, how do I interpret a positive or a negative test? Like, how certain can I be? And, we talked about this before, but just to reiterate, because I think this is so important, we have a single test that we're checking at some point after surgery or surgeon adjuvant. It has a sensitivity that's around 50%. That's a nice, easy number to remember. So that means if I actually have MRD, if I'm one of the patients that has disease somewhere in the body, how likely will this test be to detect it, right? And it's about 50%. So there's one way to look at that and say, well, 50% is not great, right? I wish we could detect everybody, all the patients. This is still substantially better than a CT scan, right? So if CT scan is the best that we have, or CT and CEA, this is substantially better in terms of sensitivity. The recognition is that if you then say, well, I'm going to do serial ctDNA, how likely is it that I will detect it by serial testing, not just a single test, but every few months? Then that number goes up much higher, right? 80+% of the time. That means that most of the time we'll be able to detect it in the blood before it is seen on CT scans. Now, the corollary is the positive predictive value. So if the test is positive, how likely is it that I really have it, right? So, so that is a very high number, meaning that when we see that positive, and we can never say 100%, because nothing's ever 100%. But if the test is positive, how likely is it that I really have MRD? I think it's fair to say that for many patients, we don't have long-term follow-up. As we saw from the really early studies, some of these patients had a positive test, but it was 3 years until the disease showed up radiographically, right? So it may just take time. So this is a number that we think is probably higher than 95%, but it'll take time to really understand that better. It is high enough that many of us in the field think that this is appropriate to enroll onto clinical trials. The FDA and others agree. They say yes, this test is sufficiently accurate in identifying that positive predictive value that we think it's reasonable to try cellular therapies and try something novel in this space. Okay, so a little quick refresher. We went through this a little bit, but what do these survival curves mean, right? When we're talking about all this, a lot of physicians like to use survival curves to describe this. So just a quick summary, and I use the same curve that we had before. This is, in this case, percent that are disease-free survival, so free of disease. So what we're looking at is everyone starts free of disease, and that over time, we kind of look at a number of patients here. So there's 8 patients. I chose this because it's a nice small number. So there's 8 patients that at 6 months here, all of them were still free of disease, but that at maybe month 10 here, 9 or so in this cohort, that you saw a positive 1 patient recurred. So we would make a note and kind of come down 1/8 here to 88%. And then maybe a few weeks later, you can see another little ditzel over, and then another patient would recur. And so as more patients recur, that number kind of goes down further. The other thing you'll see on these curves are little tick marks, right? So little things popping up the top here. And what that means is that that's that's all the information that we have on that patient. So maybe there's a patient here that had 1 draw, it was negative. 2 weeks later, or a month later, talked to the team, was seen in clinic, and then for whatever reason, just stopped following up with that clinic, and the team wasn't able to contact them anymore. So we really don't know what happened to that patient. So we add a little tick mark here just to acknowledge that that's lost information. And so this, you can look at it and say, well, most patients here are out around 3 years in this cohort, but you can see you start to lose information on those patients after about the 3-year time point. So anyway, these are what are called Kaplan-Meier curves, or survival curves is the other term that we use. All right, other questions here. If I have a positive test, how long until something appears on the scan? Now, this varies by a number of the studies, but we kind of think that it's somewhere around kind of the 8 month or so to 12-month lead time. But for an individual patient, it can be much. There's a lot of variability around it. So it's something that we're trying to define a little better in the field, and it depends on a few things in these cohorts, like how good the assay is, how frequently the CT scans being done, right? And so that you'll see these, and this is just showing for an individual patient that CT recurrence here, for example, this patient was at about 2 years, but the ctDNA was detected at baseline. Now, there are a few patients, you can see 2 of them here, where the CT scan showed something at 12 months, but didn't show up in the blood until like 16 months, right? So we do miss some then as well. So are these, when positive, are patients always positive, right? So there are some patients that may be positive and then go negative to without treatment. So kind of talked about some of the Japan data that happens in a few percentage of patients. Certainly we see that in our clinic where patients may be positive right at the limits of detection, maybe drip down below limit of detection, and for many patients then subsequently will become kind of positive again. There is noise, so these are individual patients that are kind of being followed over time. You can see most of them, the amount in the circulation kind of keep going up. There are some that just kind of go down a little bit, back up again, and then up again. So we think that the majority of the time that within the noise of the assay that patients do have, will have continued rise in the ctDNA then. But, perhaps with a really intensive lifestyle intervention and diet and other things that patients are doing, maybe we're seeing some of those clear on their own. So the other is, what does it mean if I had a stage 3 and I'm now 1.5 years out and I've been doing testing and I'm negative, right? So this curve was one way to kind of look at it, is that where are the recurrences happening, right? And so you can see some of the recurrences early on, and in this cohort at least, if they were 12 months out, you don't really see a whole lot of change. And so I think the short answer is we don't quite know yet. What we'd like to have is these conditional curves, right? Given that I'm 1.5 years out and I'm negative, like what is my outcome moving forward, right? And a lot of the data that we have is really based on, from that initial one. So I think the short answer is that it's a very good situation to be in, to be this far out and negative. Keep testing and keeping an eye on it for the reasons that we discussed, but we don't have great data to give you exact numbers, like what's the likelihood of it coming back kind of at that point, and how does that impact it? Okay, so I been doing surveillance. I have a positive ctDNA test after completing all of my surgery and adjuvant therapy at some point. Can ctDNA tell me where the cancer is hiding? And the short answer is no. It's not like a CT scan, right? You just know it's somewhere in the body. So then the question becomes, what do I do with that information, right? Should I get more frequent CT scans? And I'd say we don't know the answer for that definitively, but that's kind of common practice that a lot of us will say, okay, let's do more frequent imaging instead of a CT scan in a year. Maybe we need to start doing those every 3 or 6 months to monitor there more closely. A really common question is like, oh my goodness, should I start some chemotherapy now? And this is a really important question. It's not an easy one to understand, but I'll kind of share my perspective and how I counsel my patients around this. We talked before about there are some therapies that can cure patients with low levels of minimal residual disease, right? 5-FU and oxaliplatin are the only agents that have shown to cure patients, eradicate the disease. Irinotecan has been studied, and FOLFIRI regimen, the 5-FU and irinotecan, is not able to do it. Now, it's a fascinating question. Why can't it cure patients' disease at that setting? Maybe it's the type of immune response that's generated to platinum versus, a topoisomerase, and some very nuanced differences. We don't know for sure, but even though in metastatic disease, they have very similar disease control rates and shrinkage, and adjuvant, it's night and day. FOLFOX works, FOLFIRI does not. So the short answer to I start FOLFIRI now is to say, unfortunately, despite our desire otherwise, FOLFIRI is not going to cure the cancer, right? Instead, what it's going to do is we're going to kind of take a treatment, and instead of kind of observing, maybe do a trial, but observing a radiographic recurrence occurs, then start FOLFIRI. What one is doing is kind of starting FOLFIRI early, and recognizing when the tumor recurs radiographically, it's obviously refractory to FOLFIRI. It's growing through FOLFIRI. So then you're on to kind of second line therapy or other kind of treatments beyond that, assuming all these patients got FOLFOX before. So we don't know, and there's a lot of reasons to say maybe not, that like starting FOLFIRI early is not really going to be beneficial in extending life in this setting. And now there's, Stand Up to Cancer study randomizing patients to observation versus FOLFIRI to help address that. But I would not recommend doing FOLFIRI outside of a clinical trial at this time, because I think it's not really clear, despite our initial instinct to want to treat it, it's not really clear that we're going to improve outcomes for patients in that setting. Another question, I have resected disease in the peritoneum, right? Is ctDNA useful for me? So this kind of gets at the idea that, there's a lot of variability in how ctDNA is released in different parts of the body. And we think that, ctDNA is really good for detecting liver, for example. We just have a lot of data on that. And there's questions about, well, is a peritoneal sensitivity the same as lung versus liver? And there are some differences. And I think the data is still a little immature here. I think this is a really nice study that was done by a Spanish and Japanese group that looked at the different sites of disease and their, how much ctDNA was released and the correlation. And this is kind of a concordance in the molecular testing and their sensitivity as a surrogate of how much is being released. And what you can see is that the liver and the peritoneum at least had a very similar amount. Lung, there was a sense that there was lower levels that were released. So I think the short answer is we don't fully know, but we do think that that it can be useful for all of them. It's just they may have slightly different sensitivities based on that as well. But there's a number of other variables that impact the ctDNA shedding. So we know that perhaps site of disease does. The proliferation rate may as well. Is it a really indolent cancer? We have patients that have really indolent invisible disease in the body that are ctDNA negative, just because the tumor cells are not really replicating very fast at all. And so even visible disease sometimes we'll miss with these sensitive tests, just because of the factors like replication rate. So just acknowledging, humbly our limitations here. We really don't know that how the performance yet for all of these different sites. All right, so just conclusions here. I think we really are encouraged by these assays. These assays bring tremendous value. We don't exactly know how to fully use them, but we have a lot of enthusiasm by how we can improve outcomes for patients, better direct therapies. I would, just a bit of terminology. This is not a high risk marker. So sometimes we will talk about, oh, well, this says that patients are at high risk. Well, it's really, we are detecting disease, right? Even though it's not with a CT scan, it's with a blood test, we are detecting molecular persistence of disease. And so it's just a little bit different about how we think about it and discuss this. I fervently believe that this is a tremendous opportunity to develop new therapies in this setting. And that, this is the window where we have much lower amount of disease that we may be able to cure patients if we can be smart enough about figuring out what the treatment is that would be the best fit for them. And so I'm really hopeful that we're going to see a rapid acceleration in novel therapies in this setting and trials to really try to cure patients, right? So we want to cure patients, and can this assay help develop a setting there? And I'd say we have great support from industry. We have great support from the FDA to really develop this space. So, so I think, good momentum in that area. So really optimistic about it, but at the same time, we're in this disruptive period where, there's people that understandably want more data before changing practice, where we don't have level 1 randomized data for many of these questions. And so I think acknowledging that this is going to be a really kind of confusing time, and that it will take time for this technology for us to understand how best to utilize it, and how to change our treatment guidelines on a result of that. So with that, hopefully left some additional time for questions.
Okay, thank you, Dr. Kopetz. That was excellent. I mean, you've covered a lot of ground. So I think maybe I'll ask one question and then we can go through the list. So lots of what you said was applicable to early stage disease, right? We have a large population of people in Paltown who are interested in using ctDNA after resection in stage 4 setting, like oligometastatic disease, or, how is that different from what you have talked about?
Yeah, no, absolutely. And I think stage 4 resected disease is identical to stage 3 resected disease that are positive, right? So absolutely applicable. The positivity rates are higher. So instead of like 15%, it's kind of 40 to 50% positivity rates in stage 4 resected. But all these apply. A number of the smaller studies that are coming are allowing stage 4 resected patients on. And so I think it's especially interesting and important for our resected, patients with resected stage 4 disease. So thank you for pointing that out. I think the biology is identical. The application of the questions are really identical.
Okay, so I think maybe because we have limited time, let's start from the top of the questions and go through them. So the first one was, would like some info on when ctDNA is positive post-surgery, but then clears during 12 cycles of FOLFOX? Is there concern that the patient had the initial positive? I think you covered some of it.
Yeah,
right?
so the early data, but at least the Japanese data suggests that at least 18 months out, the outcomes look just as good as if you were negative post-surgery there. So we'll need more data. My sense is probably it's going to be a slightly higher risk, population than patients who are negative post-surgery, but really looks like the FOLFOX is working in those patients and may be clearing the disease.
Okay, so can you speak about interpreting ctDNA negative when stage 4, and if serial negative on ctDNA testing? I mean, how confident can people be that they're safe, or how long?
Right. Yeah, and I think a ctDNA negative when stage 4, I think when we think about the risk of recurrence is higher, that the sensitivity is still fairly good with a single, but again 50% range. Serially negative increases that enthusiasm and for good outcomes, but I think it's the the risk of there still being disease despite a negative test is higher with a stage 4 patient than a stage 2 or 3, but still lots of value there.
Okay, and then is that time period? They say that the most common chance of recurrence is like the first 2 years after adjuvant therapy, right? Is that also applicable to the stage 4 NED setting?
It is. It tends to be a little earlier, maybe a year and a half. But yes.
Okay. And then somebody had a question about, how to interpret the values of the ctDNA test. Like, for example, Signatera tests with the values in the tens versus hundreds. Like, how could people interpret that?
Yeah. So everything we've been talking about, positive and negative, is really, it's present or not, right? So that's the key distinction. The levels within the positive, we don't know exactly how to interpret that information yet, and whether, what that means, but it's really anything versus nothing is the key distinction right now.
Okay, and then there's a question about using epigenetic markers like in Reveal versus Signatera. What are the advantages, disadvantages, or, what would you recommend if you had a choice?
Yeah, I wouldn't go so far as to make a recommendation. I think they both have value. The Signatera is tumor informed, so that you're looking at the signatures of your cancer, so very specific there. And that the idea is that helps reduce the false positive rates. The Reveal testing is kind of understanding what colorectal cancer in general looks like. Don't just look at mutations, but other methylation factors, other epigenetic factors that may improve the performance there and the sensitivity. So we don't really know. We recognize that there are even other assays coming that will have other characteristics as well. So I wouldn't recommend testing with both. I think it's, just kind of talk to your oncologist and figure out which one he or she has had good experience with and comfort, and doing one is sufficient.
Okay, and the next question is, what is like an ideal time interval for serial testing?
Yeah, so it's reimbursed right now about every 3 months, and I think that's a reasonable time frame. I don't think more frequent testing would be useful.
Okay, so I'm just going to summarize this question. So for people with stage 4 NED, and who were negative initially for MRD and then turned positive, do you have any suggestions of what kind of chemo, if they were exposed previously to like platinum containing chemo, what would you suggest when it shows up again as positive later? Do you have any?
Yeah, so that's the kind of the hard part, because once patients have received 6 months of 5-FU and a platinum, there's not really any value of additional platinum and 5-FU, so more FOLFOX won't help cure the cancer. And FOLFIRI, cetuximab, irinotecan alone, Kate-Bev, all of those are not going to cure the cancer, unfortunately. So that's it's really about trying to think a little outside of the box at that point, continue surveillance more frequently, but we're not recommending doing any chemotherapy at that point for the reasons that I mentioned before. It's about recognizing what the goal of the therapy is at that point.
Okay, so I'll add one question here. So in Paltown, we generally recommend, when people have ctDNA positivity, to have like a liver MRI or things like that, and find out if their disease is localized, so they can do localized treatment like a resection. Yeah. What's your comment about that?
Yeah, and I think that's good to take a look and try to understand where the disease is, because I think that's the key, is that starting on FOLFIRI, for example, you don't know where the disease is that you're treating, and if there's something that can be addressed surgically, that's certainly a possibility and an option as well.
And then there's this other question: do oncologists have a sense of which stage 2 and 3 patients progress to lung, liver, or peritoneal? What are the factors like sidedness or tumor info? What would tell us what is more likely to happen?
Yeah, great question, Annie. It's so wish we had good understanding of that. We don't. There's some factors there are trends towards it, but they're not sufficiently strong that we use that to help guide our surveillance. There's still, you know, a BRAF patient may have more likely to have peritoneal disease, but we'll still have liver mets. So we are watching and surveilling all the above.
Yeah, and then Annie's other question, for the small percentage of ctDNA positive patients that, you know, spontaneously became negative, do we know if they are MSI high?
Yeah, it's a great question. You know, some of these may indeed, you know, the immune system may kind of kick in and recognize them and clear them. So you really hit the nail on the head of one of the interesting questions out there, is that if there is a small percent of patients that are spontaneously clearing, why is that, and what can we learn from that? And it may be MSI high. It could be, you know, patients that have really, you know, gotten on the treadmill and done the diet and exercise or other things that may be doing the trick as well. So that's, I think, you know, great opportunities for us to learn.
Yeah, I thought it also said that, you know, the timing of when the first test is done, right? If it's done too close to surgery, then you can get false positives. Do you think that's also a possibility?
Yeah, it's more false negatives right after surgery, right? So the, you know, this is a needle in the haystack. And so we think about the concern of the haystack being too big, right? So if there's, if you're healing from surgery, there's a lot of inflammation and that, you know, the haystack is much bigger and it's harder to find that needle. So you want that inflammation, normal DNA and circulation to diminish with healing.
Okay, so I think we'll go back to this question. So a number of MRD trials using HLA testing to stratify patients to go on a vaccine or CAR-T in Basecamp. Is HLA testing or next-gen sequencing test something to really look at?
Yeah, it's a great question. And how do we, you know, integrate some of those? You know, there are, you know, some of the vaccines are specific to certain HLA types. So that's part of the screening. You know, many of the studies though will want to repeat the HLA testing with their own assay. So it may not be as useful to get that done on the NGS as it would otherwise. But I think, you know, it's highlighting the high level of innovation in this space that are ongoing, you know, looking at, you know, cellular therapies and vaccines in this space, I think is really intriguing.
Yeah, and then the trials that you mentioned, are they're open for both MSS and MSI high patients, right?
Correct.
Okay.
Yeah.
I think we have kind of covered. I was like worried that we wouldn't be able to cover the questions. So I have this one question. For surveillance versus FOLFIRI, if progression, that would be relevant for KRAS, BRAF, who had only 2 chemo lines. Does that seem a legit concern? I mean, I was not.
Yeah, no, it's kind of, you know, the idea of, you know, using FOLFIRI early, and then if progressing, then you are now resistant to FOLFOX and FOLFIRI. So you have, you know, fewer lines of therapy remaining for treating radiographically evidenced metastatic disease. So I think, yes, a legitimate concern. And that's why we're really hesitant to recommend outside of a trial treating with FOLFIRI or other non-FOLFOX chemotherapy for ctDNA positive.
Okay, so this other question, if NED on CT scan and positive on ctDNA, is there value to repeat ctDNA 3 months and look at up-down stable trend? Is the trend of any value?
Yeah, so it's a good question. Like, what information can you get out of the trend there? We don't have enough information to know that. I do think kind of continuing monitoring still can be useful there. And it's something that I do in my patients that are kind of positive and NED on CT scan that trying to understand what's going on. And we'll commonly, you know, counsel patients on, you know, intensive lifestyle interventions and things like that they can do. And so this kind of gives a readout if any of that's beneficial as well.
Okay, I think we are at time, and thank you so much. This was very informative and it covered like everything so well. It's always a pleasure to have you with us, Dr. Kopetz.
Oh, it's always a delight. And thank you so much for your organization and advocacy in this space.
Okay, thanks everyone. Thank you for joining.